So I'm just going to start in the Australian tradition, which is acknowledging the country and where I'm standing and the traditional owners of the country I know, and the elders and the people, their traditions and cultures, and the contribution they make to our learning and our development as practitioners working with people living with cancer. And I know that's very much an Australian tradition. I cannot say anything with the right pronunciation in other languages, so I apologise. So I am going to speak, and my slides are behind me, and I have nothing here, so I am going to turn my head quite a bit, on the role of integrative oncology and complementary therapies in supporting people with haematological malignancies. And I guess we have to start somewhere, and the best place to start is acknowledging where cancer care is today. And we know that cancer care is changing very rapidly. People are living longer with all cancers, particularly haematological malignancy, and it's our priority in the healthcare system, and I love the mission of leukemia and blood cancer, that the mission to care. And this talk will be, how do we care for people who are living with and living beyond a haematological diagnosis? How do you live with a haematological diagnosis for a long period of time? And rather than the focus being on just cure and you do all the rest yourself, there's a lot that we need to do and we can do to keep people living well. So in the time that I have, it's quite a big brief and ambitious to give a sense of what I'm going to speak about. But acknowledging that there are a lot of, I'll give you a definition of what integrative medicine is and how we define it, and talk about what supportive oncology is, supportive cancer care is, and this is a global movement of investing in how we actually do the caring and not just the curing. Talk about some of the common toxicities that people experience during treatment and beyond, and here's a list of some of those common toxicities, and I'll touch on herbs and supplements, and I'm giving another talk later on medicinal cannabis, so I'm not going to speak a lot about that now. Lymphoma is one of the many blood cancers that people experience, and recently I gave a talk to the Lymphoma Nurses of Australia, and I pulled up our Lymphoma Australia from their website, all the side effects that are from treatment, and looked at the information that they provide, and I thought that would be a good guide to really look at the complexity of all of these symptoms: aches and pains, chemo brain, fatigue, nausea and vomiting, peripheral neuropathy, sleep issues, sexual health issues, skin itch, graft versus host related toxicities, weight management. There is so much that can happen to somebody who has develops a blood cancer and goes through treatment. And so I see a lot of people, and every person is different. And I see many people with different haematological malignancies as well as solid malignancies. So I see a lot of people really. And every person is different. Every person brings something else. They have a different past. They may have other comorbidities. They may be receiving different treatments. As you know, this is not static. This is a rapidly developing space with immunotherapy and CAR-T therapy and targeted therapies. Some people responding to stem cell transplants, some people partially responding and continuing on targeted therapies like rituximab or other medications. And so you need to understand the history and understand the person in order to really personalise how you support them. And so that is really the essence of what we do. So what is integrative oncology? This is a relatively new term. This is the definition from 2017 which we acknowledge globally, and this was developed through a Delphi process, so I'll read it out. Integrative oncology is a patient-centred, evidence-informed field of cancer care, utilising mind-body practices, natural products, and/or lifestyle modification from different traditions alongside conventional care. So it's not alternative medicine. It is complementary medicine. What else can we get from other traditions of healing and work and make lifestyle changes and empower people. Because the essence is that integrative oncology aims to optimise health, quality of life and clinical outcomes across the cancer continuum. And it's all about empowering people to prevent cancer and become active participants before, during and beyond their cancer. Big definition. And it's a big definition to say, oh, well, you know, do we have that here? And how do we build those programs? And that's very much what we're doing at a global level. At our level, and a little bit of background about our service, because we are very fortunate, we're the largest comprehensive integrative oncology service in Australia, and we've spent, it's now going into, I think, 9 years that I'm working with this group, running this department and working with a superb group of people. And we're a large unit. There's about 24, 25 of us, but we work, we have this purpose-built hospital. Some may have heard of or watched TV and seen Royal Prince Alfred Hospital in Sydney. There's a TV show called RPA. We're across the road and we're a comprehensive standalone cancer service for all the cancer services. The one thing we don't have, so the chemotherapy and all the infusions are done in our service for all the haematological malignancies. The stem cell transplant is still done across the road, so we don't see people during the transplant. We run prehabilitation and rehabilitation for people undergoing stem cell transplant to make sure they are as well as possible prior to that and also recover swiftly, and still in the process of publishing our outcomes. But we have a comprehensive team, so exercise, oncology, massage, acupuncture, yoga therapists, mindfulness practitioners, lymphedema therapists, reflexology, embed research into absolutely everything we do, education, and of course medical and nursing-led holistic assessments and comprehensive assessments. We work really close with dietitians and everybody else within the hospital, and work very closely with the daycare group. So we're busy and we're very fortunate. And we're fortunate, but you know, none of this is really funded. You have to be very pushy to get your funding to make things work, but we can. And there are key points for supportive cancer care, and all of you most of you have either gone through treatment, having treatment, or carers of people, or family, correct? So when you think about supportive cancer care and integrative oncology, it's really from the time of diagnosis. Many people will arrive to us having lived with feeling off for a period of time until their diagnosis. So people don't necessarily arrive well. So from diagnosis, how do we make people feel better? How do we understand what's going on for them and support them? And I particularly see this in my multiple myeloma patients. May have had back pain for quite some time, feeling fatigued, and eventually somebody says, let's check what's going on. During treatment, the treatments themselves, if you're receiving R-CHOP or you're having other chemotherapies or targeted therapies for a blood cancer, the treatments have their toxicities and are quite complex. So supportive care is really a big part of what we do, managing the symptoms using an integrative approach. So I'm going to explain what that means during treatment. And that includes giving acupuncture and reflexology in our day therapy unit. So we actually provide care and talk about how to provide that safely. Survivorship and living with advanced cancer. And I put these together now because living with advanced cancer is very real. And living with an advanced hematological cancer is, you need to be able to work. You need to be able to function. Cope with the uncertainty of what next, cope with the anxiety, cope with the chronic fatigue or the chronic toxicities. And so that's a very important part of supportive cancer care. And of course, the end stage needs to be acknowledged. I'm a palliative care specialist by training, and I'm not going to talk a lot about end-stage disease, but it needs to be acknowledged and identified. How do you support people to have quality independent of prognosis, quality time? And so you can see there are many things that are overlapping here, aren't there? So if you see supportive care or supportive oncology as an umbrella, We're all above that umbrella, all those very important disease-modifying therapies that are enabling people to live longer. We have supportive care aiming to optimise comfort and function at all stages of disease. Palliative care is for people living with an incurable cancer diagnosis, but that definition keeps changing and everyone wants to change the name. And integrative oncology, which includes this seamless integration of evidence-based complementary therapies alongside of conventional care. To provide it well, we all need to understand what's going on with all of these malignancies. I'm not an expert. There is no way to be an expert in haematological malignancies as a supportive care specialist, but I need to know what's the latest treatments. And I found out yesterday that you don't have access to all the latest treatments that we do in Australia, and I apologise that you guys need to advocate a little bit further more, but we have a lot of immunotherapy and CAR T-cell and other stuff happening probably at a different rate, thanks to having a very large research program and having a large research access to research means that you get people onto trials pretty easily, and there's a big push for that. Understanding the toxicities of all these, every new day there's a new AB or an IB or a drug that's coming out, and what are all the toxicities, so that, and what timing do people receive these treatments, and how do we manage those toxicities? So many of my myeloma patients will be on lenalidomide or similar medications. There's one called Ninlaro that causes dreadful gut stuff. So how do you manage the peripheral neuropathy? How do you keep people on treatment without reducing the dose by managing toxicities? How do you get people not to have chronic diarrhoea and to be able to stay on treatment and to enjoy food? How do you manage the chronic fatigue that people develop? How do you do that? Because drugs aren't great. How do we do this, and how do we reduce polypharmacy? So being experts in symptom management and being agile to be experts in symptom management, and of course understanding all the therapies that we provide. Now, I am not an exercise physiologist, but I have the best in my department. So choosing to partner and have the best people together and expect them to be the best at what they do and work as a multidisciplinary team. And that's what medicine is really about today, is getting together that really fantastic multidisciplinary team and good communication between team members. And for me personally, sometimes I'm myself or the nurse that I work with is the coordinator of that care to say, okay, here's the evidence, did this work, didn't it work, come back, let's try something else. It used to be that, during chemotherapy they talk to you about the chemo side effects and that's it. But we all know that there's the toxicities from the treatment, there's the toxicities from the disease, the side effects from the disease, but we also do know that it's not all chemotherapy anymore. So how do you look at the toxicities of the treatment, the implications on the person? People are going to have a stem cell transplant, for example, and they develop toxicities. How do we deal with all of the complexities of graft versus host and other toxicities when they're then waiting to go on to further treatment if their disease then progresses during that time? It's time consuming, but it's really good care. So looking at what can you do, and recognising also that young people, particularly young women who are maybe premenopausal and have a diagnosis of lymphoma suddenly develop menopausal symptoms. And how do you deal with all the other implications of being thrown into menopause, including the hot flushes, the sexual health issues, the cognitive fog that many people may experience, the arthralgias, is it from the drug, is it from menopause, is it both, and how do you tease that apart? And so there are lots of side effects, and none of these side effects occur in isolation, and they usually occur in what's called a symptom cluster, which means that it's very rare to say, oh, I've only got pain, everything else is great. So I've got pain and I really don't sleep well at night and I'm very anxious and I'm worried about what if this treatment doesn't work, and dreadful peripheral neuropathy, and you're telling me I have to exercise for my fatigue but I can't walk because it feels like when I'm walking on sand along the beach. It feels like someone's sticking needles into my feet. How do you ask those questions and respond? And the best way to ask the questions is for something called patient-reported outcome measures, that the patient, I don't love using the word patient, but the person with cancer will report their own symptoms and you respond to their reporting. So we have a lot of standardised measures called patient-reported outcome measures that enable us to identify these symptom clusters and the symptoms and what are your main concerns so that we can treat you accordingly. And so this makes this space for a holistic consultation. Now, in my younger days, I did general practice training and then I re-specialised in palliative care. So I've been studying way too long over the years, but many people are trained as doctors and nurse specialists and nurse practitioners to actually stop and take a very comprehensive assessment. And stopping and spending an hour with somebody to take a comprehensive assessment, being informed by what the patient has filled in and what are your main symptoms, main concerns, enables us to identify what's going on for somebody and build a comprehensive assessment using these patient-reported outcome measures. But what differs in integrative oncology is this piece, is that my toolbox is huge. And it's this beautiful toolbox with yoga and yoga therapists. So if somebody is fatigued and is having anxiety issues, what about yoga and yoga nidra? Doing yoga pranayama, yoga breath work. People who are splinting their diaphragm and always feeling breathless because they've got chronic pain from their thoracic spine disease. How do you, without overdoing your medications, teach people how to breathe again, and the impact of that on their ability to sleep and function and feel more at peace. So yoga exercise for every single person. I won't stop talking about exercise. Oncology massage, which is a very gentle massage by trained people. We run a 4-certificate level oncology massage program in Australia. New Zealanders can come over, and our teacher, one of them is from New Zealand, one's an Australian, and we run a oncology massage training because it's a gentle massage. It's about not being able to work with cancer patients. And there's a lot of evidence to support its benefit in cancer-related fatigue, in anxiety and distress and in pain. Acupuncture, I will speak more about, very useful for symptom management. Reflexology, using points on the feet that are acupressure points. Some may say, some will say that there's a specific map that you're working with. If anyone's ever had reflexology, it is quite powerful, and having the right person provide reflexology for us has been incredible in day therapy, turning a day therapy experience that can be full of anxiety into almost a spa day and an opportunity for deep relaxation. So thinking of how this can be delivered to improve outcomes. Qigong, in Chinese medicine, Qigong is the exercise associated. So we have yoga, which is from the Ayurvedic principles, from Indian, from the Ayurvedic medicine, the movement, if anyone has done yoga and you work through all the arms, 8 arms of the body, but you work through different, what's called meridians in Qigong or Chinese medicine, and enabling both a standing meditation as well as exercise. And it's very powerful, very possible. Meditation, diet and lifestyle changes are huge. Now, when you think about, I think about my consultation, I end up spending a third to half of my consultation talking about food and poo. And the reason I do that is the gut microbiome is obviously very important. We all know a lot now of what we eat matters, how we live matters, how we sleep matters, the amount of exercise that we do matters, and putting that together can enable people to take charge of their health again and have better outcomes and tolerate treatment better. Herbs and supplements, health coaching, lots of information, but how the hell do I do this? Wellness and health coaching is a growing space. And of course, you have to work with your psychologists and your occupational therapists and your palliative care team. And so this becomes overwhelming, and so recently we published a paper looking at a global group. Co-chair this group called the Clinical Oncology, the Clinical Practice Group for the Society of Integrative Oncology, and we said, well, what do we need to include in this history? How do we teach others to do this? And how do we empower patients to advocate so that they get the best care possible from the time of diagnosis? And divided these therapies into different groups to make it easier to identify and fund. And the reason that we put together the guidelines is to help people streamline and develop these services in their hospitals, because it's really important. As we turn the Leukemia Foundation of Australia, so one of the people that I work with is who is actually now retired. He retired. Professor David Joski, a haematologist in Western Australia, started this group called Solaris in Integrative Oncology, and very involved in the Leukemia Foundation supportive care program. So our equivalent to your group is something called the Leukemia Foundation. How do we invest in the wellness of people living with and beyond haematological malignancies? So we went to government and we've written a white paper, and we're still pushing to get funding, so it takes a while. But ultimately, you want somebody to identify your concerns, and patient-reported outcome measures make that visible to not just the person who asks, but if you integrate it into your medical program, then everybody has to see it unless they choose not to. And that's shifted the way haematologists then refer and engage people in discussions. Developing personalised plans, applying the best evidence. But a big part of all of this is empowering people in their own self-care. And whether you have access to all of these services, there is so much that you can do from the principles of integrative oncology to look at your own self-care and advocate for integrative oncology. What we've done, and haematological malignancies are not part of ASCO. ASCO is the American Society of Clinical Oncology, and for some reason haematological malignancies aren't really included in this huge organisation that is like the Bible. Everything that comes out of there is like the stamp of approval for here's this new standard of care in cancer care. But the Society of Integrative Oncology, but we extrapolate the guidelines, got together with ASCO and produced some guidelines, and these are a few of them. This is the Integrative Medicine for Pain Management Guidelines, because it helps us inform strategies. And we identified that many people will have pain, and I'm going to start, how do we extrapolate the information? I'm just seeing if for example, from studies that, so aromatase inhibitor-related joint pain. So people, and I'm going to give you an understanding of, I guess, how you can work in this space when we look at general musculoskeletal pain, chemotherapy-induced peripheral neuropathy, and other pain. People who are on immunotherapy and on some targeted treatments develop dreadful joint pain. People who may have a diagnosis of prostate cancer and another cancer may be on hormone therapy and have dreadful joint pain, breast cancer and another cancer. So, but joint pain, symmetrical, inflammatory joint pain can respond very well to acupuncture. Generalised aches and pains can respond very well to acupuncture. And so this is the strength of the recommendation. M is moderate, which means that we need to still do more research, and the quality of the evidence. And not much money has gone into research in this space, so this has really helped us advocate for money. But if you take some of these recommendations and you look at this recommendation of acupuncture for general or musculoskeletal pain, looked at 360 patients, randomised, to having acupuncture versus sham or no acupuncture or usual care, and showing that there was enough evidence to support, if you look at the usual care group and their level of pain, that auricular or electroacupuncture, and this one wasn't with sham, this is just one of the studies, showed significant and sustained reduction in pain. So if you can reduce somebody's opioids and improve someone's pain by using acupuncture or electroacupuncture. So for an example, somebody has multiple myeloma, and I have many patients with multiple myeloma. They have a lot of bone disease. Their disease is relatively stable. They've had radiotherapy. But they have chronic pain, chronic back pain. That chronic back pain impacts on sleep, impacts on quality of life, impacts on ability to be at work. And that chronic back pain is a mixed pain. And that pain can be pain on movement. It can be pain on sitting for prolonged periods. Opioids may help. And so their OxyContin dose keeps going up and up and up, and they're going, okay, and now I'm a bit drowsy, I sit down and fall asleep. No, I can't even sit at the kitchen table anymore and have a dinner. And this is a patient that I'm talking about, so they say, oh, well, let's reduce the OxyContin, add in something for nerve pain, and you add something in for nerve pain, pregabalin. And so they're on a bit of OxyContin, a bit of pregabalin, their cancer's under control, but they're on all these drugs, still, you know, doing okay, but feel a little bit drugged. And you say, well, why don't we have a look at what else is going on for this person and their pain? And you examine them, and you see that all those paravertebral muscles, all those muscles along the spine, but not actually the spine itself, are going into spasm all the time to try and protect this fragile T12 fracture that isn't quite, it's healed, but it's unstable and not a real candidate for surgery because chronically immune suppressed. And so, well, if I can reduce some of the muscle spasm, can I improve the pain? And so I would refer that person to our acupuncturist, and can I reduce the drugs and improve that person's quality of life? And so when that person, and I have a person in my head, which is why I'm speaking about a specific person, comes into my office and I say, well, look, you're on such high doses of opioids, you can't go back to work because you keep falling asleep at the computer. How do we reduce your drugs and what else can we do? The acupuncturist has given a few treatments and reduced the severity of the muscle spasm, reduce some of the pain, and enable the person to reduce the unnecessary amount of medications they're on and go to an exercise program. We know that exercise is really important. Personalised exercise with a skilled exercise specialist, our exercise physiologists that understand anatomy and understand how to work with people with bone pain. We're also doing a World Cancer Research Fund project to look at the benefit of exercise in myeloma, showing that it may assist in bone rebuilding. So we can talk about exercise for a long time. It's exciting. But reducing that muscle spasm to enable someone to exercise, to develop the ability to have to learn how to use other muscles and to be strong, that the pain is less severe. That enables you to take that person that was previously non-functioning to functioning, using non-pharmacological management of what's chronic pain, and keep them on treatment. Now, if that person also had peripheral neuropathy, so at the time of having acupuncture for his back pain, also, I'll come back to that. Also, I'll just go to the next slide actually, and I'll come back to this one. No, I won't. Also had acupuncture for peripheral neuropathy, and I'll come back to peripheral neuropathy and some of the research in that space. And then you'll say, but my hospital doesn't let us do acupuncture, we've got blood cancers. My neutrophil count might be a bit low, and what about my platelets, and is it safe to put needles into somebody who may be immune suppressed? And so Beverly DeValle, she can pronounce her name much better than I, just call her Bev, led this paper, which is a global consensus paper on how do we develop guidelines to say that acupuncture in cancer care is safe and not just effective, but what the efficacy data is, but number one is safety. Because a lot of hospitals will say, that's okay, but I'm a bit nervous having my haematological patients having any acupuncture because their platelets might be a bit down. And so we looked at the potential side effects and documented what the potential risk of acupuncture is, so bruising and bleeding, and came up with guidelines to suggest You have to have a platelet count over 40. People who are profoundly neutropenic, we avoid at that time with acupuncture. We speak to their haematologist at a regular basis, and we monitor them. So we actually, when we published it, the consensus was actually a platelet count of 20. In my hospital, we have it at 40 because I'm nervous, and so I keep it a little bit higher. And the neutrophil count below 0.5. And that was a consensus guideline. Haematologists are happy with that, and that enables us to provide that care to the right people at the right time. So if you have a treatment that is safe, then how do you manage somebody? So this is an example of Frida, one of my patients called Heather, and this is actually adapted from some modules in the Society of Integrative Oncology education piece that's available for all practitioners to access for free, and it's a QR code for everything. 57-year-old woman with a history of diffuse large cell B-cell lymphoma. She had RCHOP for 6 times, went into complete remission, started experiencing peripheral neuropathy, CIP and chemo-induced peripheral neuropathy, numbness and tingling of her feet. In her most recent visit, she reported painful pins and needles sensation in her feet up to her mid-calf, described the sensation like a string tied around her toes. She reported occasional tripping and had a near fall last month. She's been evaluated by a neurologist, told she's got peripheral neuropathy, and she was given duloxetine, pregabalin, topical pain treatment, and it gave her a little bit of relief. Now, many people in this room may have experienced peripheral neuropathy. Anyone? Yeah. It's not nice, and it can impact significantly on quality of life. So that leads me to this slide that I was looking for before on chemotherapy-induced peripheral neuropathy and the research in this space, because it's a really exciting space. What happens most of the time in cancer care, and I'm not just talking about blood cancers, I'm also talking about bowel cancer, breast cancer, so there are many drugs. So Velcade is the most common, bortezomib, and the other zinc alkaloids, as well as oxaliplatin and the taxanes, can all cause peripheral neuropathy, and we don't have good outcome. We don't have good treatment for this. So what happens is people's treatments are cut short or modified. And if you cut short or modify treatment, then what's the impact on outcome for that person? So there's this huge interest in acupuncture. So, and 55% of people can be affected. So there's a person called Ting Bao. She now runs the Dana-Farber. Dana-Farber is the big cancer hospital adjacent to Harvard in Boston, runs their Integrative Oncology program. She was at Memorial Sloan Kettering, and she did quite a few studies, but particularly one that I'm going to speak to is the multiple myeloma group, people on Velcade or bortezomib, looking at can acupuncture improve peripheral neuropathy. Small study, she's running a huge study now, but not in blood cancers because there's more breast cancer patients than blood cancer patients, but looked at a pilot of 27 patients over 10 weeks and showed this significant improvement in peripheral neuropathy symptoms in people who receive this 10-week course of acupuncture. So if you can stick needles, and the treatment effect was prolonged, and we've repeated that now with sham in different groups. What she also showed was this secondary benefit, and that's what I was talking about. If somebody's coming in for pain, they may also have hot flushes and neuropathy. Acupuncture can treat multiple symptoms at one time. You need a good acupuncturist. You need an acupuncturist that knows what they're doing. It's traditional Chinese medicine acupuncture, not dry needling. Very, very, very different things. Dry needling is often your physiotherapist says, I'll stick a few needles in here and it will release the muscle spasm, which is good for musculoskeletal pain. Traditional Chinese medicine uses what's called acupuncture points that are on different meridians. And a point in your arm here may treat nausea or neck pain. So different points, and using electroacupuncture that may help model and remodel the nerve itself. And so we're using electroacupuncture at very specific points at a very specific time frame. But a good acupuncturist can find these protocols and implement them because they're all published. I mentioned reflexology, and reflexology has been shown also to assist in neuropathy and sleep disturbances and makes you feel very relaxed. And so using multiple points on the hands and the feet can improve peripheral neuropathy and other symptoms as well. And again, acupuncture, putting pressure on someone who have low platelets, really bad idea. You don't want to bruise people. So you have to, our therapists have to, and all therapists need to know how to read a blood count before they provide treatment and care. Because thrombocytopenia, you don't want to have bruised feet at the end of a treatment. It's like, no, not doing that. But it's not contraindicated. And very quickly, because I've only got a few more minutes so that we can have time for questions, yoga. And anyone here done yoga? Yep. It's fantastic. Like, I'm missing my yoga class now. But yoga is about keeping you in homeostasis and in balance. And yoga doesn't mean you have to stand on your head and do back bends. You can do seated yoga, pranayama, which is alternate nostril breathing or other breathing work, box breathing, different type of breath work. There's something called yoga nidra, which is a deep relaxation that can really profoundly help you sleep. And so our yoga therapists will do a one-on-one and then give with a person and then give them a relaxation tape that they can listen to each night to help them sleep. And yoga has been shown to help with multiple symptoms. It's a very traditional medicine. It's been used for many generations, and very traditional medicine, but needed to be studied. And it has been studied, and there are recent guidelines for anxiety, for sleep disturbances, cancer fatigue, musculoskeletal symptoms. So I'm going to, just in these last minute, flick so I can talk about fatigue. But anxiety, depression, coping with cancer and integrative therapies is huge. People don't want to necessarily be on antidepressants and spend time talking about their cancer with the psychologist, and that access is actually very hard. What else can you do? And it's about engaging and learning mindfulness and yoga with very high evidence during active treatments and post-treatment for yoga, mindfulness, as therapies that can empower you to stay well and deal with all the uncertainties and the anxiety and the despair. I'm just going to flick through this example talking about the importance and the level of evidence, suggesting that we should really start talking about introducing mindfulness, like we have introduced mindfulness in the corporate world to keep people well. I remember, you know, Saki Santorelli and MBSR and everything that's out there. Mindfulness in cancer care, once you have a practice and it's mindfulness-based interventions, it doesn't mean you have to sit and meditate for 2 hours a day. It can be mindful walking, it can be listening to a tape. But multiple interventions can make a difference, and it gives you your own tools for self-care. And finally, just in the last 2 minutes, just talking about cancer-related fatigue, which is very mean, talking about probably the worst symptom that many people have, which is cancer-related fatigue. Cancer-related fatigue is probably the most difficult thing for people to manage, living with a chronic fatigue, and there are no magic pills for cancer-related fatigue. Ritalin, all of those psychostimulants have been shown not to work. In our cancer populations, maybe at the end of life, there's still some possibility, and people will say, well, suck it up. But actually, quite a few publications, we did one on lifestyle and integrative interventions in sleep disturbance and cancer-related fatigue, showing that we have decent evidence for exercise, mind-body therapies, acupuncture and massage for fatigue. Sleep disturbances and fatigue are married, and really good evidence again for exercise, moderate exercise for mind-body therapies, acupuncture and massage. Of course, I will talk a lot more about that when I talk about medicinal cannabis and the evidence there. But again, these ASCO-SIO guidelines come back. We've got one for for pain, for anxiety and depression and integrative therapies, and the fatigue guidelines have come out with very high level evidence too, and that S means every doctor should be recommending these therapies, like you should be recommending chemotherapy or immunotherapy or lenalidomide. You should be recommending exercise, mindfulness-based stress reduction, cognitive behavioural therapy for those people that have access to it, and Qigong during active treatment, after active treatment, and even at the end of life, it's far more complex managing fatigue. So everybody should be exercising. And we need to manage your peripheral neuropathy, your pain, your cognitive fog, which is a huge issue, multifactorial approach to cognitive fog, exercise, yoga, what herbs and supplements, and so on. And finally, herbs and supplements. Herbs and supplements are medicines. In a way, they interact with your medicines. So I can give an entire talk on herbs and supplements. Integrative oncology is not all about herbs and supplements. Herbs and supplements are really important. People will say, well, can I take my curcumin? Can I take fish oil? Can I take astragalus? What about ginseng? What about reishi mushroom, turkey tail mushroom? I'll leave that for the question and answer time. But the most important thing is, do they interact and do they cause other toxicities that may impact on your well-being, your coping, your physical symptoms? And so knowing the evidence, knowing how to find the evidence, because there's absolutely no way you can know all the evidence, looking at these herbs and supplements, having fantastic databases, talking about what you can do with food instead of the supplements, and looking at the impact of all of this on your gut microbiome and the impact of your gut microbiome. I think there's another talk on the gut microbiome, so I'm not talking about it today, makes a difference to cancer. And I'm just going to get rid of that slide and say thank you.